Hey guys, welcome to Prasu'S Medledge. I hope you all are doing good and have watched my previous videos. If not, what are you waiting for? Go for those after the end of this video. Now without wasting any time, let's get into today's topic. Today the topic of discussion is constipation. So I just want you to listen to this lecture completely without taking any notes, because at the end of this video I will be providing you with the notes. So just carefully listen to the audio, and wherever necessary I will show you the pictures. The book which I am referring here is OP Guide 9th edition. So what is constipation? Constipation is defined as a delay or difficulty in the passage of stools which is present for 2 weeks or more than 2 weeks and is responsible for causing significant stress in the children, means in the child or be it adult. But here basically we are concentrating on the pediatric aspect of constipation. So constipation can be functional or it can be due to some organic causes. So functional constipation means a constipation which is not having any etiology, like it's present as such, but we cannot determine the etiology for the constipation. Whereas the constipation which is due to organic causes are those cases of constipation which have got some underlying cause which is responsible for causing constipation. Okay, now what is the approach for constipation? When a child with constipation comes to us, what are the approaches? What is the approach we have to take? So basically the approach which we follow here is we ask for the history, and in history we ask for the pattern of passage of the stools. Then a very important thing is that when was the first stool, that is the meconium, passed by the child, because there are some diseases in which the passage of meconium is delayed. Usually the passage of meconium is occurring by 48 hours after birth, but if it is delayed, there are some diseases which are coming under those category where there is delayed passage of meconium. One such example is Hirschsprung disease, which we will be discussing later at the later session of this video. Okay, now apart from the passage of the first meconium, then the consistency of stools, then presence of blood in the stools, and we should also look for some of the other symptoms, like some of the red flag symptoms, like there will be failure to thrive, then there can be recurrent chest infections, recurrent respiratory tract infections, then there can be blood with stools. Blood in stools is basically due to the presence of enterocolitis, that is infection in the intestine. So that is the thing. Now coming to the causes for the constipation, like the organic causes for constipation. So it is divided into many subheadings. So first one is intestinal, neuron or muscular disorder. So under this we are having Hirschsprung disease, then intestinal neuronal dysplasia. Next is some of the anorectal causes like anal stenosis and rectal stricture. Then some of the developmental causes like mental retardation. Some of the drugs like opiates and anticholinergic drugs. Then some of the systemic diseases like cystic fibrosis, then hypothyroidism and celiac disease. Apart from these all causes, the diet which we take also is responsible for causing constipation. Okay, a diet which is low in fiber is responsible for causing constipation. So these were the causes of constipation, like organic causes for constipation. Now coming to functional constipation, as I already mentioned you, functional constipation is something which is not having any etiology behind it. So how do we define functional constipation? Functional constipation is defined when there is at least 2 or more than 2 criteria which I am going to mention right now. So first is presence of episode of stool incontinence per week, in a single week. 2 or fewer episodes of passage of stools in a single week. Then presence of hard stools in the rectum on per rectal examination. Then hard bowel movements for passage of the stools. Then presence of volitional stool retention, that is voluntarily withholding the stools. So that is also a criteria. Then apart from that, presence of large and hard stools which are having a large diameter such that it can even obstruct the toilet. So basically any of these, like not any of these, 2 or more than 2 out of these criteria should be present to say it as functional constipation. I hope you're clear. So by this, the definition of functional constipation is clear, I guess. So in functional constipation, what happens is basically in infants, they will scream and they will tighten their body during the passage of the stools, and in elders, like elderly children, like who are not infants, they will be obtaining some, they will be having some posture while passing the stools, like that is called as retentive posturing, like they will be crossing their legs, tightening their buttocks, and this will be a misleading feature for the parents, because the parents might think that the child is trying to defecate but he is not able to, but actually here the child is avoiding defecation. Why the child is avoiding defecation in functional constipation? The reason behind that is that here the stools harden with the passage of time as it is present in the rectum. So when there is passage of the stools, it will cause associated pain with it. So the child tries to withhold the stools. As a result, it can prevent the pain when the stool is being passing down. So that is the reason why the child is trying to withhold the passage of stools in functional constipation. Now about the management of functional constipation. So in functional constipation, we don't require any investigations as such. The management is basically disimpaction plus maintenance therapy. So disimpaction is what? There can be rectal impaction in case of functional constipation. As I already mentioned, that hard masses of stools will be present within the rectum as it is not coming out to the anus. So we have to do the disimpaction of those stools, like large fecolids will be present, and if there is any history of encopresis means stool incontinence, like soiling of the clothes will be there. So if any of this is present, then it suggests there is stool impaction. So first we have to do disimpaction, that is remove the stools. Basically we do digital disimpaction, where the doctor does the removal of the stools from the rectum using the gloved fingers. Okay, and after the disimpaction, the next thing is maintenance therapy. What is the purpose of this maintenance therapy? Purpose of maintenance therapy is to prevent the de-impaction of the stools and smooth passage of the stools. So for maintenance therapy, we use polyethylene glycol, which is given through the oral route, and alternative for that is the phosphate enema, but it is contraindicated in less than 1 year. Now in maintenance therapy, we also include other factors, like we train the child, that is behavioral training. That is, just after the meals, the child must go and go to the toilet and try to defecate. Next is we give a proper diet that is nutritious, that which comprises of vegetable and fruits, and along with that we should give adequate fluids. Okay. Now about the usage of laxatives, we do the tailor-made use of laxatives, that is based on the response of the child. We can use either one of the laxatives, that is lactulose or polyethylene glycol. Okay. So the prognosis in case of functional constipation is like 50% will be cured properly by the passage of 1 year, but there are chances of relapses. About 50% individuals show relapse even after successful therapy. Okay. Now coming to the organic causes for constipation. Suppose if we have done the medical management and we have followed the maintenance therapy and disimpaction, everything properly, but still there is constipation in the child, then it indicates there are some causes which are responsible for causing this constipation. So in that case we have to go on for some other investigations. First is rectal biopsy. In rectal biopsy we basically rule out Hirschsprung disease and intestinal neuronal dysplasia. Then we can do the MRI of the lumbosacral spine to rule out spina bifida occulta. Then we can do ANORECTAL manometry, in which we inflate a balloon within the rectum, and as a result, in a normal individual, there will be rectoanal inhibitory reflex, that is internal anal sphincter. Internal anal sphincter is going to relax, whereas in Hirschsprung disease it is not present. Rectoanal inhibitory reflex is absent. So this is the way how we exclude Hirschsprung disease, by doing ANORECTAL manometry. We look for some systemic disorders like hypothyroidism, celiac disease, cystic fibrosis, etc. Celiac disease, cystic fibrosis, etc. Then, so that's about the additional investigation which we have to do. Now coming to the Hirschsprung disease as such. Okay, so Hirschsprung disease is a very important topic from university point of view, and also from other college exams. Okay, and it is actually a cause for constipation. So it is coming under the topic of constipation itself, but we need to discuss it separately. So what is Hirschsprung disease? Hirschsprung disease is the commonest gut motility disorder which is congenital, and so since it is congenital, so it is present since birth. So the presentation will be in early infancy itself, that is there will be delayed passage of meconium, that is the meconium will be passed only after 48 hours of birth. What is the main pathology in Hirschsprung disease? In Hirschsprung disease there will be absence of ganglions, mainly in the distal part of the intestine, mainly in the rectum, that is the neurons which are present in the myenteric plexus and also in the submucosal plexus will be absent here. So the segment where the neurons are absent, that segment will be called as aganglionic segment, and this aganglionic segment, because of the absence of the neurons there, will undergo constriction, and as a result the stools will not be able to pass down. So on rectal examination, on per rectal examination in case of Hirschsprung disease, what we get is when we introduce our gloved fingers per rectally, we will find an empty rectum. But once we remove the gloved fingers out, there will be a gush of stools. So why is this happening? Because already the aganglionic segment is constricted. So the stools will be present just proximal to it, but once we introduce our gloved fingers, that aganglionic segment, it gets dilated, and as a result there will be gush of stools coming out. So this is a very characteristic feature in clinical examination which is suggestive of Hirschsprung disease. In Hirschsprung disease, apart from the constipation, there can be other symptoms also, like there can be distended abdomen also, and in constipation also generally we have some other symptoms also, like anorexia because of accumulation of food within the GIT. Plus we can have abdominal distension, abdominal pain, all those things. Those are the general symptoms which are usually associated with constipation. Now coming to the management of Hirschsprung disease, usually there is no medical management for Hirschsprung disease. We can just directly go to the surgical management, which is the definitive management. So here basically what we do is we dissect out the aganglionic segment of the intestine. So basically if you see, if this is the intestine and this area corresponds to the aganglionic segment, so we will remove it out and we will just anastomose the innervated parts already. The parts which are having the nerve supply, we will just anastomose them. So this is the definite management for Hirschsprung disease. Sometimes when the presentation is delayed because of the hypertrophy and dilation of the proximal part, means the obstruction is at a particular part and the dilation will be usually proximal to that. So in that case, first we will do colostomy, that is the proximal part of the intestine. It will be joined and it will be coming out through the abdominal skin, okay, and here we will be connecting a bag to collect the feces. So once the dilation comes down and the upper part, that is the proximal part of intestine, becomes normal, then we will carry out the definitive procedure, that is anastomosing the upper part and the lower part. So basically this is the management of Hirschsprung disease. Now finally coming to the differences between functional constipation and Hirschsprung disease. So onset of symptoms, usually onset of symptoms is beyond 1 year of age for functional constipation, whereas in case of Hirschsprung disease, as I have already mentioned, this presents during infancy because there is delayed passage of meconium, whereas in case of functional constipation there is no delayed passage of meconium. In case of functional constipation, there are two features which are not seen in Hirschsprung disease, that is stool withholding behavior plus ENCOPRESIS, that is stool incontinence. These two are not seen in Hirschsprung disease. Now coming to the rectal biopsy findings. In rectal biopsy findings, we can see ganglions are present in case of functional constipation, whereas it is absent in case of Hirschsprung disease. That is why rectal biopsy is the gold standard investigation for Hirschsprung disease. If ganglions are absent, we can be sure that it is Hirschsprung disease. Now findings in anorectal manometry. In anorectal manometry, recto-anal inhibitory reflex is present in case of functional constipation, whereas it is absent in case of Hirschsprung disease. Now abdomen findings, like in abdomen we can get some palpable fecolids in case of functional constipation, but it is not that distended, whereas in Hirschsprung disease the abdomen will be distended. So this was about the differences between the functional constipation and the Hirschsprung disease. I hope the differences are quite clear. This is just a short and simple explanation. So now I will be showing you the pics. Basically I will be showing you the text which I have highlighted in OP Guide, and you can just directly by heart those and you can write it in exam.